Good afternoon. My name is Udbhav Ram, and I'm a second-year undergraduate student at McMaster University. Today I'm here to present my research on abdominal multi-organ segmentation using deep learning to enable enhanced workflows for lower and middle-income countries. This is a great collaboration between myself and my colleagues at the University of Alabama at Birmingham. Now, before we jump into exactly what our solution is, it's important to understand what the problem is and what the current state of affairs are in radiotherapy. A current workflow would look something like this, where the patient is recommended for radiation therapy, followed by which they undergo a CT scan for planning. Those CT images are then segmented by an MD, where they identify the organs at risk as well as the target organs to be irradiated. The next step is completion of planning based on the segmentations identified by the MD. Finally, the planning is complete and the patient is ready for radiation. Now, in a developed country, this can take anywhere from 1 to 3 weeks. This depends on the complexity and the type of radiation involved. But note that this can take up to several months in lower to middle income country clinics. And this is the problem we want to solve. Now, we do this by developing deep learning models that can identify the organs at risk and the target organs. These segmentations are then verified and submitted by an MD. And this gives us a planned turnaround time of 1 to 3 hours, regardless of developed country or not. Now, the way that we develop these deep learning models relies heavily on our dataset. In this case, we're using the AMOS22 dataset, AMOS standing for Abdominal Multi Organ Segmentation. The dataset consists of 500 CT and 100 MRI image label pairs. These images look something like this, and their corresponding labels would look something like this. Now, keep in mind that while these are 2D images, we have several of these 2D images across an axis of a patient, which, when stacked together across some volume, will allow us to provide a 3D segmentation of the entire patient structure. Now, the way we use this data is, once again, we have 600 images provided from the entire dataset. We've taken 300 images in stage 1 of our training, and we split this up into 200 images for training and 100 for validation. Now, we pass this data through a UNIT-R framework. This is fairly similar to something you'd see in a number of applications currently in the field, a UNIT. Now, why it's called UNIT-R is because of the transformer encoder in the final layer that helps us with the linear projection of our flattened 3D patches. We run our training regimens on the Jetstream 2 high-performance compute cluster for around 185,000 epochs, validating over every 500 epochs. This brings us to our results. As we can see here, this box plot shows the dissimilarity coefficient by region of interest, in this case organs. Now, the dissimilarity coefficient is a standard unit for assessing the accuracy of a segmentation model. It compares the overlap between our generated labels and the ground truths for any given image. As we can see here, with the exception of the prostate and uterus, we see a fairly high accuracy, closer to 1, and a fairly low spread across the majority of organs. In fact, we were able to achieve an average dissimilarity coefficient across 7 validation images of 0.849. Now, our next steps will likely be increasing the number of iterations of training. This is because our best DSC was achieved at iteration 165,500 out of 185,000. This tells us that there is likely a lot of headroom in the amount of training we could increase and the amount of accuracy we can pull. On the same vein, we would like to increase the number of training and validation samples to use the entire dataset. Finally, we'd also like to incorporate input from radiation oncologists and medical physicists in order to transfer learn a model based on their feedback. We'd also like to highlight that all of these results were achieved in more or less 5 weeks of consistent research. So we know that there is a lot of potential with this model. Finally, I'd like to thank all of my contributors, Dr. Jeffrey Peacock and Dr. Carlos Cardenas from the University of Alabama at Birmingham, as well as Jetstream 2 for having provided the computational resources we require. Thank you very much for joining.